2023. I'm Chris Higenyi, and a very warm welcome. Before I introduce my vast array of guests who will be helping us understand what it is that is going on in as far as tuberculosis and leprosy is concerned across the country, let me just give you a preamble. The theme for this year's commemorations will be TB kills 30 Ugandans every day. Yes, we can end tuberculosis. And the slogan will be TB, what are you doing to end tuberculosis? For leprosy, it will be United for Dignity. The World TB and Leprosy Day will be commemorated in Butaleja district at Boma Grounds on the 24th of March, and events will begin at 8 a.m. and run through to 2:30 p.m. The guest of honor will be the Right Honorable Prime Minister Robina Nabanja. This year, Uganda is paying more attention to ending tuberculosis and leprosy. Prior to the World TB commemoration, there will be a number of activities which include community TB and leprosy awareness, screening, testing, prevention and treatment across the country. I'm Chris Higenyi, and again, a very warm welcome. Right now, let me introduce my panel of guests who will be discussing these issues and helping us understand. On my immediate left is Mr. Robert Nachibumba, tuberculosis activist and chairman of the World TB Day 2023. A very warm welcome, Mr. Nachibumba.
Thank you for having me.
On Mr. Nachibumba's left is Dr. Mary Nabukenya.
Yes.
Mudiope, Project Director, USAID Flagship Project at the Ministry of Health. Many thanks for making it.
Thank you so much for hosting us.
On her left is Doctor, I must specify,
yes.
Molindwa Stephen, the District Health Officer for Mukono District. Many thanks for joining us.
Yeah, thank you too.
And on all our extreme left, the lady, Dr. Turiahabe Stavia, Program Manager, NTLP, or Assistant Commissioner for TB Leprosy Control Division at the Ministry of Health. A very warm welcome.
Thank you.
If you don't mind, what is NTLP?
National Tuberculosis Leprosy Program.
National Tuberculosis Leprosy Program. Thank you very much. As we get underway, I would love to get a preamble on what TB is, but also from Mr. Robert Nachibumba to enlighten us a little bit more on this year's commemorations, including the choice of theme. If you don't mind, take it away.
So thank you, Chris. And the viewers, World TB Day, I'll start from there, Chris. World TB Day is annually commemorated majorly to raise awareness about the TB disease. And for us in Uganda, we join it with leprosy. And that's why Dr. Stavia has been telling you National TB and Leprosy Control Program.
Yeah.
So it's basically raising awareness about TB disease and leprosy in the country, but also have the same opportunity to provide services to the people in the area that we've selected. And we do contact tracing, we do community mobilization, we do screening for TB disease and leprosy. It's an opportunity for us to focus on that, but also we use it as another opportunity to try and drum up support and raise resources for fighting those two diseases. So it has been commemorated over the years, and in Uganda this year, the choice, yes, we can end TB as a theme. So we get it from international theme. We can end TB. Yes, we can. And so for us, we're focusing on yes, we can end TB because we have a duty as a country and as a world to end TB by 2030, including you, Chris. You have that duty to end TB by 2030.
2030.
And considering the burden of disease that we have in the country, as other experts are going to take us through,
that's right,
we really have a big responsibility to do that. So we're going to do the General World TB Day commemoration in Butaleja district on the 24th of March, where the guest of honor is going to be the Prime Minister of Uganda,
Robin Adabanja.
Robin Adabanja.
Okay.
But before that, we're going to have a pre-launch activity, launch of World TB Day that will happen in Mukono, and that's why we have the DHO in Mukono who's going to talk about that. And so we're going to have a multi-pronged approach. So there will be activities in Mukono, but also there will be activities in Butaleja district.
Okay.
So that's basically the briefly what I can tell you about World TB Day. We mobilize all partners in different fields, but in the health sector specifically, we sit and talk about how we're going to end TB, and we remind ourselves, and we go there not to speak to ourselves, to people from Kampala, but to speak to people who are at the community level. Okay,
that is very interesting. I'll stay with you and you take us through what exactly tuberculosis is, but I must also say I am personally challenged to do my role, and I'm glad I'm moderating this particular talk show. The fact that I come from Butaleja is a very lovely coincidence.
So we would like to put you on board, and you come and even help and drum up that. So tuberculosis is an airborne disease that's created by germ, majorly that is inhaled into somebody's lungs. And either through a person who is infected by TB,
that's right,
through talking like I'm talking, through laughing, through sneezing, through singing, and then the germs are suspended into the air through droplets.
And then,
then you inhale them. And a person who inhales them and have TB also picks TB. And so it's majorly an airborne disease. It's an airborne disease, but majorly affects the lungs. But it can, when it enters the lungs, can go to any other part of the body.
Any other part of the body.
Go to the brain, go to the bones, go to anywhere.
To the ankles?
Well, the bones are ankles. So that is how bad TB is, and that's how what TB is.
Haven't you left out the myth about how somebody can't catch TB?
Well, people can't catch TB by shaking hands.
Okay.
You cannot shake hands.
Proximity of shaking hands means you can inhale.
When I shake hands and I've not coughed or laughed off TB germs from me into the air, and you inhale them, you don't catch TB.
All right.
You cannot catch TB by sharing plates or saucepans. People have to know that at community level. You are not going to catch TB by
sharing toothbrushes.
You cannot sharing toothbrushes, certainly. No, you're not going to catch TB through that. So people have to know that TB is an airborne disease.
Airborne.
Yeah. You get it after I've spoken, I've laughed, I've sung, and I've passed out TB infected droplets in the air. Then you inhale them.
Okay. I also understand you can't catch TB by kissing.
No.
Let me go to the district health officer from Mukono, Dr. Mlindwa.
Yes.
He spoke about the fact that there will be concurrent events.
Yes.
From the commemorations in Butaleja, there will be community engagement in Mukono. Take us through that and why it's been designed so. Why not all the engagements be taken to Butaleja?
Thank you very much. Currently, what is happening, we are actually mobilizing communities to undertake certain activities. And the number one among the activities we are looking at, we are mapping out all hotspots which are likely to harbor tuberculosis. In this case, we have looked at the slums. We have a number of slums in the Mukono district. We are also looking at institutions and schools, institutions, factories, where we have congestion of very many people. And we are also looking at places like islands, because Mukono has about 19 discrete islands.
19.
So majorly we are mobilizing the masses to carry out what we call screening. We are taking off specimens to test them and confirm whether they have tuberculosis or not. Another thing that we are looking at is that we are sensitizing the masses about what tuberculosis is, mode of transmission, the signs and symptoms, treatment modalities, and how it can be prevented.
That's right.
And these activities which have already started. But I think next week we are supposed to launch on the 17th of March, and that will be Friday. It is going to happen in a place called Nama at a factory called Tiang Tiang. That's where the launch is going to take place from.
Tiang.
Tiang Tiang. So
that's a Chinese factory, right?
Yes,
okay.
Chinese factory.
Yeah.
So the number of activities, we are carrying out health education of the masses, and also we are sensitizing all leaders from the grassroots
That's right.
to the district level.
Okay. Thank you very much for that. Now, when you listen to Mr. Nachibumba, and of course taking the overview that you have given us with regard to Mukono district, it means the nation is grappling with a big or huge burden when it comes to tuberculosis. I'd like to pose the next question to Dr. Turiahabe Stavia. You are at the center of the National Tuberculosis and Leprosy Program. What is the burden of the disease to the country?
Yeah, thank you. The burden of tuberculosis in Uganda is a worrying one. Like you have read from what we crafted as part of the theme.
That's right.
The disease kills about 30 people, an estimated 30 people every day. It is not something to keep quiet about. But also, we estimate that about 240 Ugandans for a year from this very preventable.
On a daily?
Yes, on a day, 240 Ugandans. So the burden of the disease is huge. So when you compute that annually, it comes to about close to 100,000 Ugandans falling ill with TB every year.
That is quite huge.
Yes.
Children, how affected are they?
So in terms of the adults, the children, we estimate that from these close to 10 to 15% will be children from the estimate. So about close to 20,000 there.
20,000 across the country.
Across the country will be children. And majority of them also are men. Over from the data that we see, over 60% of the cases that we have in care are men. But also from epidemiology, the men are more affected by the tuberculosis germ than the women.
What explains that?
From the explanation that Robert gave us, the disease is transmitted through the air. So it means that it is going to be very well transmitted if you are in a congested setting. So the men are likely to be more in those settings. But also there are other predisposing factors that men tend to be more related with, including smoking.
Okay.
If your lungs are tainted by the nicotine from
you're
tobacco,
more at risk.
You're more at risk. Taking alcohol in excessive manner, the men are more likely to be in those spaces. Yeah, and not being able to get out there for health care. Yeah. It is the men who don't usually get out to get health services.
Men are in trouble.
Yes.
And yet policy designs always look out for women and children.
For us, we are looking out for
You're looking out for the men.
Yes.
Okay, that's quite a huge burden. And we now want to understand the interventions that are being undertaken to ensure that the disease is tackled and its spread halted, and like the goal is 2030. Dr. Mary Nabukenya Mdiope, you're a project director at USAID, flagship project to the Ministry of Health. This speaks money funding.
Yes.
How much money is the government and partners, including donors like USAID, injecting into this? What has been the trajectory of funding towards tuberculosis, and can we say, for example, that we are registering progress has set in terms of objectives and goals?
Okay, thank you so much. I think for the last 5 or so years, we have noted improving funding that is coming into the basket to support the response, the national response, with the government taking the lion's share. Most of the stuff that you see we are going to talk about that are helping to ensure that they reach the communities are employed by the government. These services for TB are provided within our public health sector, the facilities, and they still work through the district health systems to identify the private health facilities that can work with the districts and enhance the response. There is also the community structure, the VHT structure, the village health team members. Still through the district structure, we expand coverage to the reach to the communities that are having this TB. So all those structures are funded through the government with support from the partners. So where the government is not able to reach, they are able to lobby the different partners. Beyond the government, they have the United States government through their different agencies, the USAID, CDC, the Department of Defense. We also have other partners who are not USG. Global Fund is one of the major partners that funds drugs that are treating TB, even reagents. But currently, in the last 3 or 4 years, government is spending money on reagents. So that is something that is significant beyond the staff salaries that they also buy. The other things is supporting the communities. We have UNICEF that supports largely the VHT structure and enhanced by the different partners. There are other partners that are not exactly US government partners from the German government, the German Leprosy Relief Association. We have Doctors with Africa and others. So all of us come on the same table, coordinated by Dr. Stavia, and identify the gaps. What is the funding gap? Where can we touch? What meets also my mandate? And then you are able to cover that. So, but currently, we still have a gap in funding that we continue to lobby to have more to meet the need to end the TB.
One would ably say that some of the funding gaps perhaps were down to what everybody experienced across the globe, the onset of COVID-19 and the realignment of funding mechanisms across the globe. How did that affect our own interventions?
Wow, TB, as you noted, COVID actually, the way it spreads is quite similar to TB. We are talking about COVID, it was through the droplets.
That's right.
Here, we are also getting through the suspended droplets, but suspended in the air. So the transmission is similar, but also the presentation is similar. You present with the cough. The other side, they were talking about dry cough. This one is most times productive, it might be, but with HIV, it's not productive sometimes. The presentation can change a little bit, but with that having similar symptoms, it became a problem for the TB program to actually keep on identifying more TB cases. You know what came along with COVID, that when you are found with COVID, you are going to be institutionalized somewhere, you know? So the TB patients could not come.
Painful memories.
So people could not come. We had to, and then the stopping us to move, the movement ban. So people could not move freely. Most of the TB patients don't have enough money. From the studies we have seen, TB patients, even when government provides free drugs, they incur about 53% of their income just to access a service. So with that, they were not able to access a service. So we actually lost some mileage during COVID.
All right, let me go to Dr. Mlindwa Stephen. As a district health officer, I presuppose you are hands-on. When it comes to understanding what TB is for the average Chris Higenyi out there, not to confuse it with normal or usual cough, or even COVID for that matter, could you take us through the symptoms and those things that somebody can be able to quickly differentiate between TB and normal cough as a result of either flu, like some of us are grappling with in Kampala right now?
Thank you very much. Number one, sign and symptom number one, we have a cough. The cough may be productive. In most cases, it is productive, but there are few instances when it can also, the patient can present with a dry cough. But mainly we look at a cough for 2 or more weeks. Yeah. Although, even if it has not reached a period of 2 weeks with accompanying symptoms, which I'm going to mention, it also becomes very significant. Then number 2, we have those evening fevers. Intermittent fevers. Usually the patient will come complaining of, I feel feverish, something like that. We have the night sweats. These are excessive because of course, we know the normal sweats at night, but the patient will also be in a position to tell you that these days I feel I'm sweating a lot, and that's when, so those are some of the signs which can point to TB. Then we have weight loss. Weight loss, which can be,
I think that's quite commonplace.
Significant. It is also common. Then we can have lack of appetite,
which actually causes the weight loss.
It is the one which actually causes the weight loss. Yeah, because in this case, the patient doesn't want to feed. He's having those other night sweats, having the fever. So all those things are pointing to what? To tuberculosis. Then if that patient is being examined, there are things which we talk about, enlargement of the lymph nodes, because I know we have our clinical people viewing us, but also even the patient, sometimes you can feel, if you touch here, you feel that these lymph nodes have been, the swellings, they have been enlarged. Then something which I have not mentioned is about the blood in sputum. Blood in sputum. When a patient coughs, sometimes they cough blood, or they can cough sputum which is mixed or stained with blood. So the symptoms I've talked about are symptoms which are mainly common for tuberculosis affecting the lungs. But as my colleague has already mentioned, tuberculosis can affect any part of the body apart from the lungs. So if it is going to affect the bones, of course the patient is going to present with pain of the bones. If it is going to affect any other part of the body, will have to present with pain in that area, can present with, of course, if it is like a skin, can present with some skin changes. Rash, something like that. And of course, those are some of the indicators. We have also noted, especially in areas where it is not localized in the lungs, where it is affecting other body parts, you will see patient coming in with a swelling, like around this area. You find it is very swollen. And that's the time when some people start talking of witchcraft and other things, and yet it is majorly tuberculosis.
Yeah, that's an interesting perspective you bring forth. And a little bit later, Mr. Robert Nachibumba, as a TB activist, there's a lot that is down to communication and engagement with communities and how you debunk this particular mindset. You'll be taking us through that. But let me go to Dr. Stavia Turiahabe. She is, of course, one at the helm of the National TB and Leprosy Program. Help us understand across the country which areas are most affected, what is aiding that kind of picture, why a certain place is more affected than the other across the country, and what exactly informs interventions.
So I'll start from what are we doing. You had asked a while ago, what are we doing about the problem, what interventions are in place. So we start from like now creating awareness and promoting prevention. We go to now diagnosis. So the country has a network of diagnostic centers.
That's right.
Starting from health center 3 level, you can be able to access diagnosis through the laboratory. And also at that level, treatment is available. From that level onwards, the highest level in the country. So there are structures available to provide diagnosis for you in case you have any of the symptoms that doctor has just described. On top of that, we have made sure that there is treatment available across, but even at community level. Yes, and this treatment is free of charge. There's no one who's going to charge you for accessing TB treatment in the country. The government invests resources and makes sure that treatment is available. Now, when it comes to which places are more affected, like I had already said, we have subpopulations that are more at risk and have a vast number of cases, like we said, men, but we also have people living with HIV. Their risk to disease is higher.
That's right.
We have people who use a lot of alcohol, abuse alcohol. We have people who do use tobacco, people who have stayed with patients with confirmed tuberculosis, whom we call contacts. We have people who are undernourished, who live with malnutrition. All those are highly affected. Now, when it comes to and those who work in congested or stay in congested spaces, like they said, slum dwellers. When it comes to geographical burden, we do not have a specific well-studied estimate for disease per region in the country, but when we look at our national data, we see there is more tuberculosis in people around the cities. That's where we see a lot of TB. We see there's more tuberculosis in areas like Karamoja, where there's high level of undernutrition, and the whole of the northern belt also as well. That also is attributed to the way they live in those communities.
The communities, yeah.
Yes, the houses, the ventilation in the house. Like I've said, if you are staying with someone who has confirmed TB, you are more likely to have TB. The risk even increases if you stay in a less ventilated household. Yes, so you're more likely to contract the disease from the person with the disease in that same household.
That's right.
Yes.
Okay, treatment for tuberculosis, Mr. Robert Nachibomba.
Yeah.
You are an activist, and dissemination of information is very critical when it comes to ensuring that treatment models or regimes are rolled out across communities. As you explained to us the treatment for tuberculosis, and perhaps I would love somebody else would interject, because as an activist, the technical aspects of treatment could be alien. I don't want to say they are, but they may be. You'll also have to talk to us about why certain people are quick to believe that it's witchcraft, and then they go and seek treatment that might not be the kind of treatment medical officers can prescribe.
So this country conducted a TB prevalence survey a few years ago, and one of the findings was that there is massive lack of awareness about TB disease at community level, and that lack of awareness is seen in how people seek treatment, how people seek services, TB services at facilities. And so that is also combined with two things. So the setup of the healthcare system in Uganda is that you fall sick, you on your own, you're supposed to say that let me go to a health center. Yeah. And when you reach there, they diagnose you with the disease. And when you go back home, you are supposed to come back. So I wanted to start from that point of view. So there is free treatment for TB, like Dr. Stavia has put it, in Uganda. And there are effective drugs that we have, 6 months treatment for the normal TB, which they call drug-susceptible TB. The clinical doctors will tell you that, drug-susceptible TB. And if you take the treatment as you're asked by the physician, you heal. And TB is curable. That's what people have to know. Unfortunately, there are so many socio-economic issues that are surrounding a TB patient at community level. poverty. We are talking about TB treatment being free, but a person walking from home to a facility, it takes money. And like the Dr. Savia said, health-seeking behavior that we have, especially for us men, you feel you have cough, you first say, let me go to that drug shop, you buy yourself Septrin, you take, you go to go and see which doctor, and you first see which doctor, and you don't get well, so the disease is building up. And the most dangerous person is the one who has a disease and is not treating.
Not treating, yeah.
Because that is the most dangerous person to the community. So people end up spending a lot of money, not on the disease itself, but on other issues. And that's why Dr. Mary said 53%, they call it catastrophic costs, the costs that are involved for one at a community level to go and get treatment, despite the fact that treatment is free in the facility. So there are so many issues, and that's why we encourage at community level that we get people who, we first of all raise awareness, and that's what we're doing with World TB Day. Let people know that TB is airborne, it's not witchcraft. Let people know the signs and symptoms that the DHO put out. Let people know that these are myths, so that you are not fooled around. And when you get the TB disease, you go and get treatment. Because there is that treatment when we fail to treat this normal TB, and then you deal that around, you develop what they call drug-resistant TB. Now that's very expensive.
You've just posed a question to Dr. Mary Nabukenya. TB drug resistance and the tendency for people to misunderstand everything around treatment. 60 days of treatment require some bit of discipline on the part of the victim or the patient. Now, 6 months rather.
6 months.
Most of us don't have that discipline. I must be very humble about it. However, if you have a support system, perhaps at home, then you can be able to succeed at it. Just take us through the treatment modules that are available, and also debunk the myth about what is drug resistant and what is not.
Okay, thank you so much. Robert has talked about the simple TB, but we call it uncomplicated.
Uncomplicated.
Yes, it's not exactly simple. 6 months, if we are given amoxicillin for 5 days, you also struggle to finish the 5 days. And it's normal for all of us to say 3 days, my cough has gone, do I have to finish? Really? My problem is gone.
Hey, all along I was feeling guilty.
Yeah, it's normal.
All right.
So even for TB, when you start your treatment, there are 4 drugs at the first 2 months that are used, but the good thing is that all that is mixed in those tablets that you will receive. Okay, so you cannot say this is the drug, let me leave it out, let me leave this one is not sweet. So you get a tab that contains all those 4 drugs for the first 2 months.
That's right.
And then the next 4 months, if you have progressed well, you will have 2 tablets that are a little smaller and fewer, definitely. So that is the uncomplicated TB. But during that time, as you are taking it, you are being monitored to check that you are progressing and you are getting better. Okay. But most times when you start that treatment, the good thing that within a month, the symptoms will subside. You will start eating, you will want more food, your cough will subside. And sometimes we hear people saying, I'm not able to give you sputum to check whether I'm cured or I've converted. But usually the health workers know what to do to help you get the sample so that we are able to be sure that you are improving, you are getting better. So what we need is actually to get somebody to work with you to ensure that they support you. Even when you don't have those symptoms that you had at the time of presenting, you are able to continue. Because there is a repercussion for not continuing.
That is right.
For the 6 months ending. And that repercussion is that the drugs that are used, some of them kill the drug, the germ, others make it become dormant.
Dormant.
Yes, so you need it longer based on the research to ensure that we are sure you don't have the germs. They're not going to wake up when you stop the drug.
Okay.
So they behave different. So when you don't take your medicine well, the germs will come back when now they know the other ones, they can resist the initial drugs that we are talking about. And this time around, you will need higher generation drugs, antibiotics.
For the youth and the young person out there, perhaps we can say, if you do not take your medication as religiously as prescribed by the doctor, that means the germs will be going to the gym and come back stronger for you.
Yeah. Exactly.
So you should be able to do exactly what you are told by your physician. Then there is also the crisis in the country of the counter access to drugs, and then the availability of counterfeits that completely disorganize the treatment regime for when you're fighting a disease like this one. How is it being addressed?
So here in Uganda, most of the drugs that we have, they are effective and they have been tested. The problem that we have over the counter, that these antibiotics, there are some single antibiotics used for treating other conditions. They are available in the pharmacies. So when this man here, Robert, when he gets the cough, he feels he has some money, he can pick it, 3 days, the cough has gone, and go over the counter, buy it. That one tablet, you're supposed to be using 4 drugs at once, at the same time, for the drugs to work on the germ. Okay. So when you buy that drug that will take away your cough, you are again helping the germ to go and exercise, to come back in a worse way. So that, how we have managed to deal with that is that we get drugs from one supplier. The country manages that through the Global Green Light Committee, through WHO, to ensure that the drugs we are getting have been approved and endorsed by the World Health Organization that come through the country. And these are made available freely everywhere as close as possible. And you have heard Dr. Stavia talk about now to the community. So to ensure that people don't go to shop over the counter.
Okay. What I'm grappling with is, I think, the average cough. There's one that is like a wave across the city. Who can give me an explanation of what's going on? Dr. Mulindwa, what's going on? Everyone is complaining about cough, flu. Some of us are afraid it's mutated COVID.
But I think it happened sometime, was it last year? And research tests were carried out, and a diagnosis of Haemophilus influenza. Yes? Haemophilus influenza was made. Of course, those are
it's also their viruses.
Those are viruses.
But maybe to add
Please.
on, for example, for us who are in the cities, you know that the quality of the air we breathe is not the best. So the irritations are so many.
Okay.
Yeah, on top of the infectious germs, there are other things that can happen and cause us a cough. But we shouldn't sit on that cough.
Of course.
Yeah, we need to get out there, talk to the health worker. We did a community-wide screening like we are going to do now last year in September. And that time, there was also a bout of the same coughs that you are talking about.
Okay.
So we found that among the many coughs that were there, actually a good number had tuberculosis.
Oh my God.
So don't sit on that.
No, not at all. All right, Dr. Stavia, I'll be again coming back to you very shortly to take us through the national, the 2030 target to ending TB, what that entails, how it's been structured in terms of phases, and what is going to happen where, and who is supposed to be involved at what point. But before you do that, let me ask Dr. Mulindwa, Stephen, to take us through the prevention and control mechanisms for tuberculosis.
Yeah, the prevention and control, there are a number of ways in which we encourage our people to prevent tuberculosis. And the number one, we are looking at early detection and the treatment. Just in case somebody has signs and symptoms, we want that person to go to the health facility, we confirm the disease, and we start that person on treatment as fast as possible, because that could control spread of germs to the rest of the people. Number two, since it is a disease which is airborne, we normally encourage our people to improve on infrastructure where they sleep. Issues of putting windows, because I visited some households in slums. You find there are no windows. The doors are too small, which are kept closed. If you stay in such environment, most likely you will get the tuberculosis if there is somebody who is already infected. Because what is important is to have good aeration in the house where somebody stays.
That's right.
Then number 3, we need also to improve on the nutritional status of our people. When we talk about nutritional status here, I'm focusing mainly on what we call a balanced diet. At least this thing of eating green vegetables, it has always been encouraged so that we boost the body immune system to diseases.
That's right.
Then the other point is that we encourage regular screening. Regular, especially if somebody is having HIV. Because as the Assistant Commissioner has already mentioned, these two diseases can coexist. Somebody has HIV, since HIV is a disease of immune suppression, at the same time can get what? Can get tuberculosis. So we need to continue encouraging our people to go for periodic screening, especially in areas where somebody has the signs and symptoms of tuberculosis. I think majorly those are some of the ways. And what I haven't mentioned maybe is limiting on the number of people who are staying in a certain household. Because you know these small rooms of 10 by 10 feet, you find about 10 people are staying there. So if one of them is sick, most likely it's going to spread. The
economics of the day sometimes dictates that people stay like that. You had something you wanted to add on prevention and control?
Yes, on prevention. Yeah. For those that have had a patient, it's not the end of the world.
That's right.
You know, when we get that germ, it's not immediate that you get that symptoms and disease, what we call disease. You get the TB infection, but it's not yet a disease. And there's something that can be done at that step. So we talk about preventive therapy, where the contacts of non-TB patients are actually given preventive care. Still, that treatment is free of charge. And as long as you have been confirmed not to have TB disease, you can actually be given that preventive therapy. And previously, we started with the children under 5 years. Now the children even beyond 5 years can receive that preventive therapy. Also, the people living with HIV, if they have not received a full course of preventive therapy, they can also receive that to prevent progression to TB disease. Yeah, that is also available free of charge.
All right, as we wrap up this hour and the discussion on tuberculosis so that we can create time to talk about leprosy, the National Tuberculosis and Leprosy Program, what is the strategic plan that has 2030 as the main goal that we must end tuberculosis? Is it even possible, given the fact that we are pushing ending malaria, ending HIV, ending other kind of diseases, and then we have tuberculosis? How does it play out? Very quickly.
Thank you. We have said yes, we can end TB.
Yes, we can end
and
TB.
We want to end it by 2030. So the Ministry of Health has come up with a people-centered strategic direction where we put Ugandans at the center of the TB response.
That's right.
Every Ugandan has a stake in making sure that we achieve the 2030 end TB target. So take your role seriously.
That's right.
So we are asking, even in this World TB Day commemoration, what are you doing to end TB by 2030? So every individual in Uganda has a responsibility. How are you using this responsibility? You have a responsibility. Thank you for being here today to take us through this session.
It's an immense honor.
You are doing your role. And you are supporting this strategy to end TB. So in this people-centered strategic direction, we want to make sure that everyone out there who needs a service related to TB gets it.
That's right.
And we are achieving this through making sure that Ugandans understand the disease. Once we understand the disease, there will be no question, it is witchcraft, it is...
Yeah.
Okay.
There will be no question, it cannot be cured. I have the disease, it is the end of the world. No.
That's right.
Having TB is not the end of your life. It is a curable disease, it is a preventable disease. So other than awareness, we are promoting prevention, like they have said. What they have not said about prevention is preventing severe disease among children.
Yeah.
Through immunization at
Through
birth.
immunization at birth.
True.
Yes.
Yeah.
That one is very key for every
immunize.
woman who is going to have their baby right now. They should be thinking of doing their role, making sure that this child gets immunized.
That's right.
Yes.
All right.
If
I was still
Dr. Stevia-
continuing.
Okay. You have 15
Yes.
broadcasting seconds.
Yes. So prevention,
Yeah.
early diagnosis and treatment initiation. Early diagnosis, we have made the infrastructure to make the diagnosis for you. We shall diagnose you with TB, but in case you got TB from someone who had resistant TB, we shall also make diagnosis of the resistant strain, and both of you are treatable and you can be cured. The other key strategy is to make sure that we work with you through the treatment journey, as we monitor and support you to complete your treatment, thereby stopping the transmission.
All right. Dr. Stavia Turiahabe, Program Manager at the National Tuberculosis and Leprosy Program, also Assistant Commissioner, Tuberculosis Leprosy Control Division. Many thanks for that insight. And many thanks to you too, Dr. Mulindwa Stephen, District Health Officer at Mukono District. Dr. Mary Nabukenya Mgyope, the Project Director, USAID Flagship Project at the Ministry of Health. And I see Mr. Robert Nachibomba itching, but I have to sign out for the first hour so that we can allow time for leprosy discussion to go. So, Robert Nachibomba, I'm going to have to say no.
Thank you.
All right, the hashtag on Twitter is #NTBUganda. And of course, just a preamble that the World TB and Leprosy Day, March 24th, it will be commemorated in Butaleja district on the part of Uganda. Let's go for a break, but the discussion still continues. We shall be tackling leprosy for the next 1 hour. That is something you don't want to miss. Stay with us. We welcome those that went with us into the break. If you are just joining us, welcome to a special program that is being held ahead of the World TB and Leprosy Day, the 24th of March, that is going to be commemorated in Butaleja district. The events will begin at 8 a.m. to 2:30 p.m. and the guest of honor will be the Prime Minister, Right Honorable Robina Nabanja. The theme for this year is Tuberculosis kills 30 Ugandans every day. Yes, we can end TB. The slogan, what are you doing to end TB? And for leprosy, united for dignity. Now, this hour, we shall be changing gears and speaking leprosy. But before I do that, I would like to allow for 5 minutes so that there is clarity on an aspect about tuberculosis that we need to hammer down. That was discussed behind the scenes as we were in the break. It was a matter of a vote. Who is going to do that for us?
I think I can do it.
Please go ahead, Dr. Stavia Turiahabe, the Program Manager at the National Tuberculosis and Leprosy Program. She's also the Assistant Commissioner, TB Leprosy Control Division at the Ministry of Health.
Thank you once again. Commemoration of World TB Day every year involves a number of activities.
That's right.
But last year and this year, it is unique in a way that they come at a time when we launched community-level tuberculosis screening, awareness, testing, diagnosis, and prevention.
That's right.
This is in line with the national strategic direction of empowering our communities and strengthening community engagement in the TB response. So this year we will have, we expect that in every community in Uganda, there is work related to creating awareness about the disease. There is work related to screening community members. there's work related to linkage of those that are found to have the disease to the health system. And there is prevention taking place at the community through provision of preventive treatment to the people who are eligible, and there is treatment for patients who will be diagnosed with the disease. We do an intensive 5-day activity everywhere in the country, focusing, especially this time around this March, on communities that are hard to reach, communities that are hotspot, that we are likely to find more TB in those communities, and communities that rarely come to the health system. We are looking at schools, we are looking at islands like we've been, the DHO will be explaining. We are looking at people, workers. They rarely have time to take off to go to the health facilities.
You have to make money.
You have to
take running around.
We have to make ends meet. So we are reaching out there to reach you with the TB service. Be responsive, and we should be able to support you in case you have the disease, to treat you, you'll get cured, and your loved ones will stay TB free.
That's right. That's a very interesting and important point. Your loved ones. Many times people's decisions are not attendant to the fact that there are loved ones that will be affected. So when you emphasize that, those that have ears, please listen. Your loved ones are important. Now let's switch gears and of course stay within the same mode and come to discuss leprosy, which is also part of this whole initiative. Dr. Mary Nabukenya-Mudyope, the project director at USAID, flagship project at the Ministry of Health. We would love to understand leprosy. My surface area knowledge and the interaction I've come close to victims is a case of breakage of skin, toes. I don't know whether it is a misrepresentation or I'm close. Just take us through that.
Okay, thank you so much. Leprosy is caused by Mycobacterium leprae. TB is
Mycobacterium
leprae. TB is caused by Mycobacterium tuberculosis. So these diseases are quite similar. They are quite similar, but the difference is we know that TB goes to the lungs first and can touch any other body part. But for leprosy, this is a slow-growing disease. Slow-growing disease that targets the nerves. It goes straight when you get it. The way we get it is through droplets, again, in close contact with somebody, which is quite similar to TB, but it takes longer to show signs and symptoms. But when it gets into the body, it goes and targets the nerves. So wherever you can feel, if you know that you have a part that feels, leprosy can touch there, because we feel using nerves. So these droplets, when they get in there and you don't feel, definitely anything that causes injury, you will not detect it early, you will not feel it. So people will lift saucepans when they are hot and feel like, you know, these days I've cooked for a long time, I can lift a saucepan without feeling, and it is okay. But in reality, you are burning yourself. So you will get a wound or a burn, and before you know it, the wound is there, and because you are not feeling, the blood flow in that part is also not good. So the wound will stay there longer. The wound is there, but it's not painful. You get it. But the commonest, that is a little bit extreme. The commonest way it shows, it goes into the nerves, the skin feels. So when it reaches the skin, it will actually cause discoloration of your skin. It starts very small, like a pea, size of a pea. So you get a patch as small as a pea, cow, as small as that. But the skin color there where it is, where it's starting from, will be lighter than your skin color. So your patch will be maybe darker than mine. Or if I compare with Dr. Stavia, the patch will be different, but
That's
you have
right.
to compare with your general skin color. So that patch, if you try to pass there with cotton and you don't feel anything, a cotton wink, not a piercing, not a pin, but a cotton wink. If you are not feeling in that patch, then it will be helpful that you check. So those are the early symptoms of leprosy. but it takes like 5 years to even 14 years without getting a symptom from the time you got infected with the leprosy germ.
And that effectively brings me to our next question. You've just enlightened me and opened my whole mind to, if it can take 15 years to realize, then we have a huge burden on our hands as a country. We could be having a whole lot of people suffering or infected, and then we have no particular idea. But we have the officer at the program. Just take us through what the state of affairs is and what the burden to the nation is.
Yeah, thank you once again. Compared to tuberculosis, we see leprosy as not very big problem.
Okay.
Why do I say that? Uganda achieved or attained an elimination status for leprosy, so we are not considered a high burden country. So for leprosy, we are looking at achieving no Ugandan developing the disease. We are also thinking by 2030. But like we have had...
Why? Aren't we loading 2030 with a lot of things?
No, 2030 is the time where the world is looking at ending most of the
infectious diseases. Yeah.
Why?
But
I'm sorry to digress from the discussion.
because these diseases keep the world back in terms of poverty. And so we have to deal away with them for the population to be productive and get engaged into the development of
understood.
different countries.
Continue with that.
Yes. So for leprosy, we are targeting having no Ugandan developing the disease. Unfortunately, still see some Ugandans falling down with the disease. Because we achieved elimination of it as a public health threat, there was a relaxation in the system in trying to identify people with the disease. So the few who are there, who remained there, continued to transmit the disease. So as we integrated now the search for leprosy into the search for tuberculosis, recently we have seen the numbers of people coming out with the disease increase. Just last year, we saw over 500 Ugandans coming out with the disease. 12% of these were children, meaning that these children got the disease recently from the adults.
From the adults,
Yes, so there is transmission taking place. On top of that, over 15% of the people we found had already achieved disability.
It was visible on them.
Visible.
They had lost the fingers, the hands, or they couldn't see, so there was disability in them, meaning they had been with their disease for quite some time, but they were not accessing the health system. So the burden is there, the numbers are there, but people are not coming out. They think, I think the different things miss. They think maybe it is witchcraft because we are not still creating awareness about it. Whereas there is less awareness about tuberculosis, it is more known than, in its less awareness than leprosy. People think leprosy is no longer part of us, but it is there. So people are out there with the disease and struggling.
In terms of mapping, what particular areas of the country do we see more prevalent leprosy than others?
For now, I would say there is a lot of acumen in where we see a lot of the cases, in my view. The health system in those spaces, specifically West Nile, the health workers are more alert in looking out for the disease compared to other parts of the country.
Why?
Because when we went to the community level, even places which had spent over 10 years without giving us a leprosy person in the system, we found some
all of a sudden.
Yes. So it could be that the health system in some places is not very alert in identifying the people, and in some places it is more responsive. But that said, we see a lot of leprosy in the border districts, and more especially in West Nile sub-region.
Okay.
And this, we attribute this to the burden also of the refugees there, because most of our refugees come from countries that are still in the high burden countries of leprosy. So they still have a lot of leprosy in them. So it's likely that some of those cases cross over and cause transmission to these border districts of the country.
You ably ended that submission with a transmission. That is a spread.
Yes.
Dr. Mulindwa Stephen,
yes.
you are in Mukono, and many people out there, when we talk about leprosy, or who are watching right now, might be wondering, now, the person in Mukono, in just one sentence, say it in Luganda. Leprosy chechi.
Leprosy bulwadde bwa bigenge.
Bigenge.
Tubuyita bigenge mu Luganda. Naye nga bwe buba engeri gy'obufunamu tugamba droplet nga omukulu oli bwe yannyonnyodde luli. Omuntu yeeyasimudde obuzi obwo obuva mu nnyindo oli n'akola ki n'abusika atalina bulwadde obwo.
Perfect.
Yes.
Let's now switch. How does leprosy spread?
Leprosy is spread by droplet infection.
Yeah.
And when we talk about droplet infection, we need to think of if somebody is talking, if somebody is singing, if somebody is laughing, if somebody is coughing, releases those microorganisms which are going to be...
What are you talking about, doctor? You mean every day in what we do, how we live our lives,
yes,
we are under threat?
Yes, true. You know, especially if you are seated next or close to somebody with the disease. Because if you sing, if you cough, if you sneeze, all those microorganisms are going to be inhaled by the other person and eventually will get infected with the disease.
Okay.
Yes.
And
so
that
in
is
other
why
words, it's airborne.
It's airborne.
Just like tuberculosis is also airborne disease.
Interesting.
And that is the importance of cough etiquette.
Cough etiquette.
Cough etiquette, very important.
So,
prevents many diseases.
All right. Interesting there. Mr. Robert Nachbumba.
Yeah.
In your dimension, and I keep emphasizing, I might appear like I'm singling you out, but activism is very important in disease control, disease information dissemination, people to understand what it is, how it spreads, how it can be prevented, and how it is treated. But also to agree and find closure when you have the disease to be able to seek treatment. There are people out there who do not go for treatment because they are afraid to be judged as either bewitched or unlucky. Tell us about the mindset regarding this disease across the communities and how that is affecting all intervention efforts.
So, Chris and the viewers, infectious diseases can only be eliminated with sufficient information to the patient and the community and support for both the two. So if you have leprosy and you don't know that you have leprosy, chances are that you develop into what Dr. Stavia talked about. By the time they get you, you have advanced and you've gotten into disability state.
Yeah.
So for us, we encourage and we really speak about having information at community level. And that's why I want to recruit you, Chris, to get into activism for leprosy and TB, because the interaction you've had with the doctors here, you must be getting scared because they may need to take your cough today and see if you're coughing this other dust.
Pretty much. I'll be humbled by the opportunity to be attended to by experts.
But the point is, the point is,
just before you continue, on the screen out there, if you are watching and following us very closely, there is a phone number that 0781-27701, and you think there is something that hasn't been explained very well, or something that you have grappled with in terms of a lack of knowledge on leprosy and tuberculosis, please do share your concern or question, so that later we shall have one or two or even all the experts help us understand exactly what you are asking. It will be very good that you are enlightened. So, Mr. Nachibumba, please do continue.
Yeah, I was saying we need to empower the community to have information.
That's right.
And what you're talking about, stigma,
Yeah.
comes from lack of information, lack of knowledge. You don't know that this is leprosy, and that's why. And this is how it's spread, and that's how you end up stigmatizing the person who has the disease. So people need to get that knowledge and information as much as we can give it. 2, the people who are found to have the disease need support to complete treatment, to go through the treatment and complete it. And that's why, like Dr. Stavi has been saying, we are talking a lot about community interventions, and community means the patient-centered approach that she's talking about. Let the patient be supported. All the interventions that we're doing it for the sake of the patient, with their needs put into consideration. So the patient may need somebody who helps them to take treatment. The patient may need somebody who supports them to the facility. The patient at the community may need psychosocial support, counseling.
Is this available right now as we speak?
And that's what we are. That's what the strategic plan is talking about.
Okay.
The National TB and Leprosy Control Program strategic plan, putting that at the center of the patient. But we have not yet achieved it
You haven't
so well.
achieved that.
And that's why we are speaking to the people who are listening, who are watching, to know that these signs and symptoms depict leprosy, they depict TB disease, support the person, know where the services are. Dr. Stavi has said the health facilities up to the lower level.
That's right.
Let people go there, and they are referred, and they are treated. And also us at community level, we support them.
When I was younger, I used to see Ministry of Health vans very frequently, going through communities and with a loudspeaker, and clinicians, or are they clinicians or health workers, speaking and generally interacting at a more intimate level with the community than it is today. I do not know, I could be wrong, after migrating to the city, where you might not see such a truck along Kampala Road or even in Wandegea or in Ntinda. Are these communication campaigns still running?
So in the World TB and Leprosy commemoration pre-events, that is one of the activities that is happening and is going to happen, continue happening. Around Mukono, there are vans that are mobilizing people. So there are 2 vans, one that comes and mobilizes the populations. Then the second one, called the mobile clinic, that comes with the health workers to screen and help people. So the ministry has not regressed, especially the National TB and Leprosy Control Program under Dr. Stavia's leadership. Is actually moving forward, and there's going to be a lot of that in Butaleja. 2 weeks to World TB Day. So we are going to do a lot of that in Butaleja, in Butevo, in Tororo, in Chibuku, and Budaka. Those 5
districts. I'll want to understand why, but that will go to Dr. Habstabia a little bit later. Why have you zeroed in on those districts, and particularly Butaleja, for the commemoration? Is it a rollout of national events, or Butaleja has a specific issue that can be addressed? You will tell us that very shortly. But before you do, I'd like to engage Dr. Stephen Mulindwa, the District Health Officer from Mukono, on the treatment of leprosy. I see within the literature that I have Hansen's disease. Hansen brought leprosy. Did he carry leprosy to Uganda?
The treatment of leprosy is almost similar to what we do when somebody gets tuberculosis, because even here we are using a variety of antibiotics.
That's right.
And the treatment takes 6 months.
Wow.
Yes, majorly that. But because as Dr. Nabukenya explained, these antibiotics are combined in one tablet. So it is not like we are having different tablets with different varieties. Some are combined together and they are taken at once for a period of 6 months.
Okay. If you don't mind, please explain why I see Hansen's disease. I need to figure out, Dr. Mary, I
Yes.
think, yeah, take me through that.
Okay.
If I find Hansen, I'll be like, watch what related leprosy.
No, science
So, yeah.
for discoveries, the way we name diseases
Okay.
and the drugs is to do with who discovered it
Who
first.
discovered it
So the
first.
name lives as the disease lives.
Okay.
So you just get
ideally-
that the person becomes known because of their discovery.
But not bringing
Not bringing the disease.
You know, when you say that, somebody out there could be like, I'm going to have to look for Mr. Hansen. All right, so that is interesting. So if you tell a doctor about your experience of numbness and a loss of feeling in certain parts of the body or in patches of the skin, this could be caused by nerve damage from the infection. Is any damage to the nerves a sign that things could be going leprosy side?
So yes.
Or you can actually be suffering from something else.
It can be something else, but the testing is
Okay.
what makes
Is
it
important.
cardinal.
Yeah.
The way it is tested is what makes it cardinal. Sometimes you have heard about people who are numb, but they feel pins and needles.
Yeah.
It's different.
That's different.
You are feeling,
Oh.
you are feeling, but what you are feeling is pins and needles, like something is piercing you. The nerve is affected, but in a different way. So this one you don't feel. So somebody will use the cotton, you don't feel. They bring the pin, you are not feeling.
Okay.
Something like so. It's different. That's why you get the wounds, and you end up losing the different parts of the fingers and the feet because they are more likely to get damaged first.
That's right.
And also the eyesight and the eyesight. They will come and you will continue staying awake when the fly is passing by, and before you know it, the fly falls on your eye and you get infection.
Yeah.
Because the eye is not feeding, so it's not able to blink when you need to blink.
That is right.
Something like that.
Dr. Turiahabi Stavia, the people in Butaleja will be asking a fundamental question. And we are very critical thinkers. And when we see a national event on leprosy, people are waiting for national events on PDM so that money can come, and all of a sudden it is tuberculosis and leprosy. Why?
Yeah, thank you so much. We are going to Butareja so that when PDM actually comes, you are ready and strong to be part. You are not down with TB, you are not down with leprosy. You are ready to take on the development
right.
in the PDM. So because we have said there is limited awareness about the disease across the country.
Yeah.
So one of the criteria we use to choose where to go is whether we've been there before to support that district to create awareness or not. The other criteria we use is whether we think in that district people are accessing the services or not.
That's right.
Through seeing who comes in to care. The other way is to see whether people in that district, when they get the disease and they are diagnosed, they keep in treatment and the treatment is completed successfully, and many others that I will not mention. So for Butareja, one, we want to create awareness. Two, we want to make sure that people actually are accessing services. So we want to urge the people, and you can send them a message that let's make sure that we reach all the corners of the district with TB awareness, leprosy awareness, and screening. And we see whether actually we have this monster there in plenty, or it is actually not there. So we are coming to help you to see how we can improve access to TB and leprosy services.
All right. So if you are in Butaleja district and you are watching the show, I'll simply say, abasangu bali huja ohuba bitiramu ehingambagana ne leprosy ni tuberculosis eshe shhololo bali huja ohingamba humo bahunga magesi gosi agawetaga ohuba oba mulamu ebesa ja PDM ni jola ogifuna bulani.
Wow. Wow. He's become my activist.
Oh. Prepare the vouchers. All right, let's transition, and of course, still within the confines of leprosy. I would like to come to Dr. Nabukenya. You said, and the funding regime when it comes to disease prevention, control, mapping, we overly depend. And when I say overly depend, it could be relative, depending on which particular sector you're in. What is the ability of government when it comes to budgetary allocations to be able to roll out interventions required when it comes to treatment of diseases like leprosy and tuberculosis? If the taps are closed, aren't our people going to die?
The taps from the donors?
Donors, yeah, the cash taps.
I think what we have observed over time is these are bilateral discussions between governments. I'm coming in with this aim. This is what there are modes of discussion. You discuss what is your role, what is my role. So usually the negotiation points are that I will be able to meet this. Please also play your role here and here. That's how you hear that most of the donors are not exactly recruiting staff. That is the contribution of government. That is government. That yes, I can come, but please make sure you have the staff that are going to run the service. I can facilitate this, but also government can say, yes, I have money to have the staff there, but I'm not able to run some of these community activities because maybe they are very, very expensive. I'm able to reach 50%, not able to reach 100%. I would like to be at 100%. Then you come to a common ground. Each of them plays their role to ensure that we reach everybody that has the symptoms that needs a service. So those are not like the donor is coming and I'm just going. But also, as you heard about the strategic plan, even when we talk about the strategic plan, they talk about next year milestones. What will be the funding, their projections? What will be my contribution to that? And looking at their projections also for the funding projection, they are able to say, okay, next year we are not sure. Please make plans to ensure that you can cover what I've been able to cover in the earlier year that I'm sure of. So every time, and the ministry puts progressive reviews to ensure, to check how far have we reached, what is the issue, what can we check in, who else can support us here and there if this one is not able to support.
That is right.
And as you look at the performance, how much of the population we have reached.
Dr. Mlindwa Stephen.
Yes.
I'm sure as a medical officer, you are presiding over a whole set of other doctors. They could be senior house officers. I hope they are not still on strike in When you talk about the ability of the public healthcare system to meet the demands of treatment, prevention, and any other services that may be needed within Mukono area, how is the rollout?
Just as the Assistant Commissioner has already mentioned, Mukono district, we have a total of 38 public health facilities, but out of these, 21 are offering these services, treatment for tuberculosis and also trying to look out for leprosy. So these services are decentralized from Health Center 3, and that is the facility which is found at sub-county level, Health Center 4, and the district hospital, including the private not-for-profit hospitals like Nagarama Hospital. So we have a number of services taking place at these facilities. We have already talked about the diagnosis and treatment of clients, but we also have something to do with the implementation of what we call the directly observed therapy, short course. And in this case, we have health workers traveling from health facilities. They go down to the villages where these patients are, and they administer treatment from there.
Okay.
So in terms of readiness, in terms of how the system is ready to support implementation of these activities, I can say that Mukono district is at 90% ready.
Wow.
Because in addition to that, we have a number of gene expert machines which are supporting diagnosis of this disease. One at Mukono General Hospital, one at Nagarama. Setanas Go Center 3, we have a gene expert machine there, and also Koja Health Center 4.
Okay.
So we have made sure that we strengthen the capacity of the district to diagnose these diseases. And we have also oriented, because we already have trained workforce, but we have reoriented them about these diseases, especially our health workers who are working with the private sector.
Okay.
Yes.
All right. Very shortly, we shall allow for a little bit of questions from members of the audience who are watching from across the globe. And I'm particularly interested in this very first one that the eye landed on. Hello. This one is writing from Butaleja. Hello. Is it in order if I realize that I just got into contact with a TB patient and just start on treatment, than using the patient's drugs? From Butaleja TC, that is Butaleja Trading Center. This one I think is confused about proximity to one who has TB, and whether if you have come into contact with a person who has TB, then you are right away in danger. Who can answer that for this particular person?
Thank you. We define contacts for people who have TB as close contacts or casual contacts. So if you have, assuming you have TB, God forbid, if we stay with you for prolonged hours, 8 hours, and for over time,
yeah,
then we become your close contacts. So for example, if you have your father or mother diagnosed with TB and you're a child in that household, and that's where you sleep, definitely, then you are a close contact to your father. So you need to worry. But if you are at school, for example, and there is a visitor who visits this school today, and all of a sudden they say this visitor had TB, then you are not at risk.
You're not at risk.
But if your teacher has the disease, or your classmate, or your roommate in the dormitory, then you are a close contact, because you stay with that person for prolonged hours, most frequent exposure.
Okay, another question. Good evening. This is Mark from Kigali. Just to be brief, last year I failed my medical exam in Dubai due to TB, but I had no any signs or symptoms. They deported me. It was an easy time for me, but I had to accept the situation. I was told I had TB, but when I went to Kisugu Health Center, Kisugu, that is in Kampala, they made some check through saliva, but found out that I was negative, and it was still hard for me. The doctors there transferred me to IHK for chest x-ray, and they also found that I was TB negative. In Dubai, I was checked, I was positive. In Uganda, Kisugu, I was negative. How does this happen?
Okay.
Maybe Dr. Berry.
Yes,
is it possible that tests can show both negative and positive at different intervals?
Actually, would be good most times to test using the same platform. If we say microscopy, if you are going to validate. Even the technician, so that whatever results that you get out depend on the user, the technology, and its specificity or its sensitivity to help you get the disease.
That's right.
Yeah, so this is Dubai. We don't know which systems they used, and this is Uganda.
One can
and we have different,
very efficient systems.
Yes. So, but most of the time travelers, they use a lot of the X-ray. They do use an X-ray, and the X-ray, yes, we use it, but it just tells you that this lung is maybe not okay. But the cause, it doesn't tell you the cause. Okay. You can find a lung that maybe has issues, but the causes of that abnormality within the lung can be various. So for them, if they use that, but most of the travelers, they use X-ray. They ask you to take an X-ray, and TB is one of those that causes abnormality within the lungs.
Okay.
So,
maybe also to, based on that, to help the public. For example, if you come to the health facility and we test using now the most specific and more sensitive test is the gene expert.
Yeah.
If we test you and this machine says you have TB germs, sometimes you may not have the symptoms by now. It is not good for you to hop around in denial looking for another result.
Alternative.
Because the other result may be negative. It also depends on how you have expressed yourself in terms of picking the sputum that we have tested at this particular moment. So it would be good that you take the treatment and complete it instead of hopping around between facilities looking for the diagnosis.
Okay, Dr. Stephen, answer this one for us. My question is about, okay, the person writing here, please do not say it's Chris. The nerve damage and its effects can also be created by diabetes. This is according to this person. Should we say diabetic people may get these symptoms and we miss testing for leprosy thinking it's uncontrolled effects of diabetes?
Not really. We shouldn't. Because as she explained, you know with leprosy, we have talked about nerve damage. But the diagnosis in leprosy is clinical. We use the clinical approach. Majorly, we are dependent
evidence-based.
Yes, evidence-based and the signs and symptoms.
Okay.
Yes. When it comes to diabetes, of course, if somebody is having complications of diabetes, number one, there will be history of somebody having diabetes. If it is not there, we shall detect that using a machine. When we check, we shall find out that the sugar levels are extremely high. Yes.
All right, Kavise Penny, live and clearly watching this program from Entebbe. I'd like to inquire from Dr. Stevia to highlight on how one can get to know that he or she is affected with leprosy. I think Penny joined us at a time when that had been pretty much discussed. I don't want to go back to that particular explanation of how, but I think we shall be able to cover it as we do our wrap. Let me just sample two, and then we continue with something that Dr. Anna Chibomba wanted to talk about. Hi, thanks for the spirit of love for teaching all Ugandans as far as TB and leprosy is concerned. I'm Wani David Franco, a lab assistant. What's the difference between cavitary and latent TB infection? Wow. Cavitary. C-A-V-I-T-A-R-Y.
Okay.
There's also something that is interesting here. Why is it nowadays streptomycin tablet is no longer used frequently in treatment of TB? Now, this one seems to be a very knowledgeable medic. His or her employee of these names shows that there's... what's the difference between cavitary and latent TB infection? And why is it that streptomycin tablet is no longer used? Who goes for that one? Dr. Mary?
Yes, for cavitary, those that get that, there's evidence that the lung is damaged. And most likely you will have even symptoms, or at least you are likely to cough. But latent TB disease, it's not actually latent TB disease, it's latent TB infection.
Latent TB infection.
Yes, so that germ is there in the body, but you have not got any symptoms that are caused by that disease, that germ, the Mycobacterium tuberculosis. So you have it in the blood, but you are normal. You're okay, something like that. But cavitary, most likely you are going to have symptoms, and one of those is likely to be cough. So you will have most likely a disease, the TB disease. So that is TB disease, and the other one is TB infection. Latent is infection.
All right, let's first leave the questions that are coming in from our audience, from wherever you are watching. We do appreciate the fact that you are part of the talk show, and of course you are seeking to understand the dynamics involved in as far as tuberculosis and leprosy are concerned. Of course, it's we do appreciate the fact that this effort is already beginning to bear fruit. Let me now return to the crux of our discussion, and of course we are at leprosy. Mr. Robert Nachibomba, you spoke about a run.
Yeah, one of the activities that we are carrying out to commemorate World TB Day 2023
That's right.
is a TB marathon. We had
Wait a minute. You want people suffering from TB to run again?
Well, it's not the people suffering from TB. It's people running in support
All right.
of TB and
In support.
leprosy.
Okay.
And it's it has 3 objectives. One of them is resource mobilization. The other one is awareness raising, the biggest.
The biggest, yeah.
Yeah, the biggest. And the third one, I said earlier, the entire thing is also service delivery, because at the marathon we at the venue we have activities, screening and yeah, whatnot, testing. So this year we're going to have a marathon, and I'm bringing it up to link it to what Dr. Mary was talking about with the financing. There's a big funding gap for TB management in the country, especially community-based activities. So we are conducting that run to raise monies and build a TB isolation ward in Iganga Hospital.
Iganga Hospital.
Yeah. So we did a marathon last year, and we are doing another one this year. Last year we're going to do it on 28th of May, and I would like to encourage all corporate companies and individuals to really support that run, because it's for a noble cause. The burden of TB in this country, you cannot know how it's going to affect you. Like the gentleman who is telling you about the experience he got in Dubai. So we are trying to get those resources and build an isolation ward. But after that, because it's going to be an annual activity, then we shall look at another pressing issue and dedicate those resources to that. So Chris, I'd like to call upon you to, if you're a runner, to join, but also importantly to contribute to that.
Okay, no doubt about that. I was once a very dynamic sportsman. Broadcasting has done its share in distracting me from that. Now, as a call to action, we are winding up, and as the time races to the hour mark, I would like to begin from Dr. Stevia Triahabe. What is the call to action? Wrap this up on your part.
Thank you. I want to start by encouraging all of us that yes, it is possible to end TB by 2030, but you must stand up and do something wherever you are.
That's right.
If you are a community member out there, get the information that we are bringing across during this time and also beyond. Understand what it is, this disease, tuberculosis, what it is to do when you have the symptom. If you are a health worker out there, let's welcome the people that come to us. It doesn't matter whether you're in a private facility or in a public facility. When someone comes to you, think about tuberculosis. Save this Ugandan, the money that they spend moving from facility to facility looking for a diagnosis of what is affecting them, the fever that has been long-standing, and you are not, it's not malaria, it's not HIV, but you are still not thinking TB. Think TB because it is common in our country.
Okay.
If you are a private person out there, you can do something still. Like he has said, you can contribute to the response and support this community initiative and support the different activities that or projects that we'll be putting across. So for the run, even if you don't run, you contribute by putting in something towards the TB response. Now for this march, we are coming to you, wherever you are. Take up the services that we are bringing to you.
That's right.
As part of your contribution to end TB by 2030. Thank you.
Okay. Dr. Mlindo Stephen, to the people of Mukono.
To the people of Mukono, number one, at individual level. Whenever you feel like you have the signs and symptoms of tuberculosis or leprosy, I encourage them to report to our facilities because the services are free of charge.
That's right.
Then to the rest of the opinion leaders, like the teachers, like the health workers, let us be on the lookout for these cases because we know TB TB patients can be found in congested places, but you have places like factories in Mukono, we have slums, we have islands. So let us all be on the lookout. We identify these cases and of course refer them to health facilities for appropriate treatment.
Okay. Dr. Mary Nabukenya, I hope you announce a new check in terms of funding.
Thank you so much. Since I'm from the donors side, representing them on this panel, I would like to encourage everybody that can play a part to contribute a resource. The resource can be human resource, the resource can be money, the resource can be time. And all of us in our different communities, Chris, you're already playing a role.
I'm humbled.
Yes. As media, as a media player.
That's right.
So each of us, even when I'm a professional, what do I do when I'm at home? Do I stigmatize somebody who has a symptom that I'm aware of or I've heard about today?
That's right.
If somebody has got the symptom, I should help. But if they have been diagnosed with TB or leprosy, I should also support them to take their treatment and cure that. The others, if you know that you are within at the workplace, please be an agent. If you don't have the cough, you are breathing the air of that person. So support them to ensure that they access care. There is a toll-free line, 0800 100 066. 0800 100 066. Please call the ministry, call us. These days we have actually differentiated. We can find you. If you have you are stigmatized, we can find you where you are. That's why sometimes you don't see that the vehicles of the labeled ministry coming up.
You have intelligence.
Yes, so we can come and find you.
I hope you're not aiding police.
No, we'll explain ourselves so that you allow us to meet you where you are comfortable, to meet you and provide a service. Yes, so for the men, please invite us, we can reach out.
That is right.
You don't have to come to a health facility if you don't feel comfortable.
Mr. Robert, rather, activist.
Thank you. I would like to call upon the viewers and all partners that we are holding World TB Day on the 24th of March in Utaleja, and all partners in that region and members of the public, you are welcome to that function that will be at Boma Grounds in Utaleja. I would also like to inform the public that we have a World TB Day launch in Mukono at Tiang Tiang on 17th, Friday 17th. It's an important activity-based launch. Please, partners and anybody who can support those activities, please go ahead. I would also like to remind again the public that we have a TB run or TB marathon on the 28th of May, and we are running for a cause of building an isolation ward, TB isolation ward in Iganga Hospital. Any support that you bring in, moral, material, or what is welcome.
All right. Well, thank you very much, Robert Nachibumba, TB activist and chairperson of the World TB Day 2023. Thank you too, Dr. Mary Nabukenya Mudiope, Project Director, USAID, a flagship project of the Ministry of Health. And many thanks, Dr. Mulindwa Stephen, District Health Officer, Mukono District, for your insight and perspective. And many thanks to Dr. Stavia Turiahawe, Program Manager, National Tuberculosis and Leprosy Program, also Assistant Commissioner, TB and Leprosy Control Division at the Ministry of Health. I must say the information, the insight, the perspectives shared here will go a long way in emboldening the people's knowledge of tuberculosis and leprosy, how it presents, but most importantly, how best they can be able to prevent it. For the people of Butaleja, on the 24th of March, all roads will lead to Boma grounds, and the people there will, of course, be getting the opportunity to understand what TB is, and if within the communities out there, there are those that are grappling with the disease and should be able to access treatment and any other information, please do ensure that you bring them on board. Shinahabe shamani nyo mwesi ni mungoeyo mwaja hu Boma grounds. This is Chris Higenyi. I am Chris Higenyi, that is Intelligent. It's been a pleasure hosting this talk show and of course being at the forefront of ensuring that information dissemination reaches out as effectively as it should.